Hey Fix listeners, I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
Variety of opinions here, and I think we have so much to learn from the areas where we agree, but I think we have a lot more to learn in areas where we disagree, and we can kind of help people that are listening to the show kind of find their own way in things by learning from experienced guys like yourself speaking on these topics. And wherever you may differ, people can kind of find themselves in different places and sort of figure out the way that they want to approach these full arch cases, and that's what we're all about. So again, thank you guys so much for coming on, and welcome to the show.
Well, thank you.
So
pleasure to be here.
Yeah, for sure. And Dr. Damon, welcome as well, of course. Welcome back.
Yeah. Thanks
Okay.
For having me again. Good to see y'all.
And Soren, I suppose you're welcome too, though you may be the co-host
Hey,
of the
everyone.
show. I want to make sure you knew you were welcome too.
Yes.
I'll kind of talk a little bit about just sort of the format of the debate, and then I'll kind of lead in with the introductions for you guys as well, just to give people context if they don't already know who you are. So for this format, for this debate, we have a few different topics here, and I'll start by just giving some context from the topic, where we're coming from, what the subject is, and kind of a little bit of the perspectives that I've heard watching you guys' videos and going to lectures and things like that. And then we'll be taking turns giving Dr. Stanley and Dr. Damon the opportunity to speak on the topic, go ahead and give their perspective with whatever supporting evidence that they have today. And then after that, the other will have a chance to respond. And then from there, we'll kind of moderate sort of a more open-ended discussion, as well as present some questions that we put together ahead of time for those topics. And then we'll just kind of let those live out as they may. We'll try and find a middle road if we can. And if not, we move on to the next thing. And then from there, we'll see what our audience has to say about it. And maybe in subsequent episodes, we can do some follow-ups and talk a lot more about it. So I'll go ahead and get into our introduction. So Dr. Damon, I'll start with you. So Dr. Damon is a dentist and educator with extensive experience in full arch, from advanced surgeries to prosthetic fabrication. He is the owner and operator of Texas Implant Dental Centers in Dallas, Fort Worth, and Amarillo, Texas. He's completed thousands of fixed arches and educates doctors on everything from basic all four to the most atrophic cases we encounter, utilizing zygomatic implants, pterygoids, and other accessory techniques to treat the most difficult cases. Dr. Robert Stanley is with us. He is an oral surgeon and diplomate of the ABOI and the ICOI. He is a continuing education instructor and founder of the Stanley Institute. His channel has posted over 400 videos on the topics of dental implants, guided surgery, and full arch dentistry. He is also an adjunct instructor at the UNC Chapel Hill, and somehow has found some time in his day to come on our humble podcast. So I really appreciate that.
Thank you.
Of
Dr. Toll,
course.
real quick. I do oral surgery, but I am not an oral surgeon.
You're not an oral surgeon.
No.
I could have sworn you were an oral surgeon.
Yeah,
never
I
knew.
do a lot of surgery. So it's a common mistake. But I'm a dual trained PhD in engineering and dentist.
Okay, very good, very good. Well, you fooled me. I could have sworn you were an oral surgeon, but I appreciate you clarifying.
Yeah.
Okay, so we'll get into our first topic, and that's going to be the role of zygomatic pterygoid implants and other remote anchorage techniques. One of the most popular topics in full arch dentistry currently is the utilization of extramaxillary techniques such as pterygoids and zygomatic implants. Dr. Stanley, in your video, I don't need pterygoids or zygomatics in my practice, you stated that 99% of patients can get by without the use of pterygoid or zygomatic implants. With the focus on advanced techniques that we're seeing in the full arch landscape, there is a notable asymmetry between what you say and also what the general consensus around full arch seems to be, that these techniques are indicated a lot more often in full arch patients and they can be usable even on a daily basis. Could you elaborate a little bit on this point, and how are you able to circumvent some of those situations where most providers are opting for some of these more advanced techniques?
Sure, I'd be happy to. So the first thing that we need to make sure we understand is that doing these remote anchorage solutions, they're not contraindicated, okay? They're just another tool in our toolbox. But as it happens in so many things, not even just dentistry, but just in life, when something new comes along, there's energy and excitement, and people have a tendency to jump in and go, oh, I've learned this new technique, and then on Monday they see a case, they go, well, I could actually do that on that case. And so what I feel like what we're having right now is just we've got a deviation from the mean, where we have a lot of people that are learning about these remote anchorage solutions, and yet the traditional root form implants are more often than not sufficient to suffice for just about, like I said in my video, 99% of the cases. So what does that mean? Well, it means if you actually do a prosthetic protocol where you start with the teeth and then you back into where the implants, and you use some CBCT scans and optical scans to do that, you can almost find enough bone. Almost always find enough bone. And so you go, well, if I'm finding the bone, then you have to ask yourself, well, if I've got enough bone to do an all on X, but between the sinuses or between the foramens or something like that, then why would I want to bring into my practice this other solution? Well, the first answer is if you don't have that bone, then that would be a good place to start looking, right? So you would start to look at other places. So that's the first thing. The second thing is that you would say, well, I'm looking for increase in stability. And as a mechanical engineer, you can imagine that I have a very strong belief about reducing mechanical complications through basic mechanical principles. And having a distal cantilever that's excessive can really cause a lot of problems. And so, you look to the literature and you have a lot of people that are saying, if we don't have a terminal abutment on our prostheses, there's a lot of complications associated with it. And that's true. But there's a couple other things that go into play here, and that is the type of materials that are being used to implement these solutions. So for instance, let's say you're doing an FP1 where you just have regular crown and bridge height. You don't have a very tall bridge, right? Your beam is rather narrow. And so if you have a long span cantilever with a small interocclusal space, and you don't have a strong implant, if you put all those things together, it's like gasoline and matches, right? You put yourself in a position where you're going to have a lot of complications. However, if you take on the philosophy that I'm only going to cantilever small amounts, enough to get me to first molar occlusion, and I'm going to use zirconia for my final prostheses, and I'm going to do FP3, so I'm going to have a minimum height of, say, 13 to 14, 15 millimeters of arch height from the incisal edge to the intagular surface, and you use a reputable implant, which is made out of like a titanium alloy, then all those problems go away. So at that moment, you say, well, can I get by with first molar occlusion for the vast preponderance of people? And it's been my experience is that most people that need full arch are about 55 years old, and they haven't enjoyed their smile their entire life. And what I mean by that is that they've either been plagued by rampant caries or they've been plagued by periodontal disease their entire life. So at 55, when you tell them, listen, Mr. Smith, I can wrap you in a warm blanket, put you to sleep, and wake you up in an hour with a brand new smile, that's pretty powerful, right? And that's the kind of space we're living in. Now, let's say you don't have all of those things don't align, and you don't have enough bone. Well, that's when you would want to look to one of these road anchorage solutions. And my contention is this: unless you've set up your practice in a way where you're doing these all the time, you don't need to be doing them. And what I mean by that is, if you're not doing something all the time, like I mountain bike on the side, right? If I'm not in the field, if I'm not out in the woods mountain biking, I get rusty. So if I'm not doing these advanced techniques often, I'm going to get rusty, right? And then that's when you can really hurt someone. So my contention is this: if you don't have those conditions in place, then I would send it to someone who does. I would send it to someone who's qualified, who does this. Basically, the one guy in the county or the town or the city or the state that is, focuses on this one solution, because they're so rare. I mean, the indications are so rare to need them that when you need it, send it to somebody who's qualified.
Okay. Yeah, no, I think that's an excellent position. So before we get into, rebuttals on those points, I know we're all kind of taking mental notes about a lot of the different things you said, and I appreciate your well thought out response. Dr. Damon, would you like to take a turn in this as well?
Yeah, I mean, I think that there's definitely some things that I agree with. Talking about doing a maximum of a one-tooth cantilever, talking about doing FP3. I'm a big proponent of FP3, And same with zirconia, and making sure that your zirconia thickness is adequate, right? So minimum of 13. So I think there's a lot of stuff that I definitely agree with. Where I tend to have a different philosophy is just, well, let me ask Stanley this. Are you doing, so typically all of your all-on-X cases in the maxilla are anterior to the sinus?
I would say, if I had to guess, I'd say about 50%. And the reason is that we have the new short implants, right? And so that allows us to get a short root form implant, typically in that second premolar, sometimes even in the molar position. And it helps to eliminate needing to do a lot of sinus grafts as well, because you can get that posterior anchorage you're looking for with the new short implants.
And so you're just doing this subantrally?
A lot of times, yeah.
What size?
The short implant that I have available, I mean, the shortest one is 6 millimeters in length, and it's a 5.2 in diameter.
Hey guys, I just want to take a beat to talk about one of our sponsors, SIN 360, specifically their full arch digital workflow. Here at the Fix Podcast, we've been using SIN for about 2 years, and one of our favorite integrations from this workflow is the Micron Mapper. Photogrammetry is an absolutely pivotal technology that has changed the way full arch is being done. It's allowing us to capture implant scans in under 5 seconds with micron level accuracy that's beating any type of scannable verification jig or analog verification jig, what have you, and it's able to do it in under 5 seconds. And guys, SIN 360 is absolutely giving this thing away right now for $699 a month for 39 months with 0% financing. Think about that, $699 per month. That's about the cost of an analog conversion or fabricating an analog verification jig, or maybe even just a scannable verification jig. So I highly, highly, highly recommend you try this out. It's one of the most pivotal investments that you can make in a full arch digitally capable practice. To learn more, visit sin360.us/thefixpodcast and get yourself a Micron Mapper today.
So yeah, I mean, I'm not. There's no biomechanical advantage having 6 implants anterior to the sinus. The four is all that you need, and in fact, if you're going to do 6 anterior to the sinus, and if this patient ever needs a revision, they're going to be an automatic quad. You're going to have so much iatrogenic bone destruction when those implants get removed. I don't advocate for 6 anterior to the sinus. I mean, I definitely appreciate Dr. Stanley's desire to want to be safe and desire to want to have the best outcome for the patient, right? And there's absolutely nothing wrong with referring. I think I do agree with Dr. Stanley in the fact that we are seeing a deviation from the mean. I think it's because a lot of young docs, I mean, I can't tell you how many docs out of school come in to take my full arch course. It's their first course, and they've already done 10 to 20 arches, and I'm like, okay, wait a minute, where did you guys get your education? And they're just blowing and going. So I don't know how to describe it. Maybe a lot of younger docs are just very hungry and willing to take on a lot of risk. I think that they don't even know the risk that they're taking on. So I kind of think this deviation from the mean is not only just with respect to treating atrophic maxillas, but I think it's also guys getting in and jumping into full arch way too early. So I don't know. Dr. Stanley, do you think that there's something there?
I would have to concur with you. I did a course recently. I was invited to teach a course for 2 days, and it was like a DSO, so they procured their patients, their doctors, And about halfway through the first day, you get a sense for the level of understanding in the room. And there were only 4 people in that room of 70 that should have been in there. The other group of people should have been in the onesie twosie implant course. They shouldn't have been in the full mouth course. It was kind of shocking.
Yeah,
I would
so
say,
go ahead, Soren.
yeah, I was just going to say, I feel like there's so many, whether it's podcasts or just hype around full arch dentistry right now, where these large DSO groups are, they are needing to fill that void of patients, and they also want to sell these treatments, right? But they don't want to pay for providers who maybe have been doing this for 10 years. So their solution is to make full arch dentistry like the new cool thing to do. And I feel like a lot of these groups are sending doctors right out of school because those are the people that jump into their office. They come into the office to get surgical experience, to take teeth out, and then next thing you know, they're kind of like pushed into, let's do full arch dentistry, and then they end up in courses like yours, Clark, and probably the one that you were teaching as well, Dr. Stanley. And I agree. I think it's really scary. I see a lot of cases coming from those clinics, and Tyler and I, being the clinical director for a large group DSO, we saw the quality of some of these treatments being done, and they were very much under par for sure.
Yeah, I mean, I think something that we're kind of touching on here is that, for one, you have people who are inexperienced, sure, getting into full arch, and there's questions about who should be doing full arch and who's really qualified to do that. And I think that's an entirely different subject altogether, as valuable of a conversation as it may be. But one thing that I think becomes a little bit contentious is, especially, as it is relevant to the topic too, is, when we start talking about the advantages of, let's say pterygoids, first of all, right? I mean, we can talk about zygomatics because those kind of come into play with really atrophic cases where you have no subantral bone really, and nothing really in zone 2 whatsoever. But with pterygoids, one of the purported benefits of it is, you go from talking about what is a tolerable cantilever to having no cantilever at all. And a lot of people can purport the benefits of that and saying, okay, well, we have absolutely no cantilever. That's clearly better than having some, right? And then you start to hear things about that being, potentially even a standard of care. So now someone says, okay, well, I'm experienced enough to get into full arch. I'm starting to do some all-in-4. I'm doing that. I'm running into some problems here and there. I'm having a posterior tilted implant fail. Then I'm having to graft it, and I'm having to deal with all this. I need something else to kind of supplement where I'm running into trouble. And then they hear people talking about the biomechanical advantages of completely eliminating the cantilever. And so they're saying, well, if I'm already doing, upper all-in-4s, now I need to be doing pterygoids. And so there's just this sort of immediate succession into a different level of care if you're going to be doing some full arch. So, we've kind of already lowered the barrier of getting into full arch in the first place. There's a lot of advancements in the past few years that have made this a lot easier. There's a lot of podcasts that have come around telling people how to do these things, or at least pointing them in the right direction to get into it and start doing it even exclusively. And then it's just sort of this very stepwise trip into doing really the most advanced level of care that we do. And I guess the question is, what really is the indication for it? Of course, we can talk about those benefits. There's also risks that come into play. And so I think really it comes to question is, how necessary is it to do, say, a pterygoid? I mean, yes, we can completely eliminate the risks that are associated with, I wouldn't say completely, but we can really mitigate the risks that are introduced with a cantilever. But is it worth it to go that extra step and start doing that extra, more advanced and potentially dangerous technique for the sake of doing that? And it's a risk-benefit analysis. And so, Dr. Damon, I'll kind of point to you because you were the person that definitely pushed us, myself and Soren, to do a lot more pterygoids. We already had kind of been introduced to the technique, but for us, it was more of, okay, this is to help us rescue ourselves when we have a tilted fail. You kind of changed our mentality a little bit as young doctors into thinking, okay, if I start doing pterygoids more often, even on cases where I could get away with it, I'm going to have more success long-term because I have less biomechanical stress. Can you speak to that just a little bit and maybe kind of provide some guidance on that?
Yeah. So, I think one of the reasons why I wanted us to interview Dr. Stanley is because, I do pterygoids on 99% of my cases, and he says 99% of his cases don't need them. And I was like, man, this will be a
contradiction.
perfect, this will be a perfect discussion, But yeah, so, Dr. Stanley, to one of your points, right, about like, if you mountain bike just on occasion, you kind of better be careful and not go on a super tough trail. But if you're mountain biking every day, you're ready for the Olympics. So there's a small degree to that, right? So like you can't be ready to treat the atrophic maxilla if you don't practice the atrophic maxilla on a regular basis. Now that doesn't mean that we put zygos in on people that don't need them, but I can't think of a reason not to give my patients a pterygoid, and so everybody gets them, right? So we go with the no cantilevers. Wilkerson has a really good biomechanical article talking about pterygoids and how it reduces the stress when you compare it to the standard 4. So we're eliminating stress and strain, increasing our stability. And where I challenge Dr. Stanley with doing the subantral, shorter implant. Well, I would prefer to do that over a sinus graft and then come back in place. I would first prefer to do a pterygoid because one, we can utilize a longer implant. My average pterygoid implant length is 18. And we're able to really lock it into the pyramidal process, which has a lot of very dense cortical bone. And so our cumulative torque values go up, the stresses come down, and I see less failures, I see less prosthetic complications. In fact, I don't see any prosthetic complications with the pterygoid, other than if you have an 85-year-old patient, on occasion they can't handle the pterygoids. I think their tongue gets pretty big, and they just don't like it. That's the only patient that I can think of that doesn't need a pterygoid is a elderly female patient. They just don't get along well with stuff in their maxilla. But that's kind of my rationale for doing pterygoids on everybody.
Yeah, I would say, yeah, and I'm curious as well about Dr. Stanley. If prosthetic, when I say prosthetic failure, I don't mean like in zirconia, but like fractures of temporary loaded. Are you typically doing like 2 to 3 month temporaries in your office and then transitioning to zirconia after those 2 to 3 months?
Yeah, so we do immediate provisionalization, and that would be a prefabricated provisional. So we just pick it up that day, but it's prefabricated. And then we let them wear that. It's a nanoceramic, and we let them wear that for 6 months. And the reason we go a little longer than most people in the industry is I really want the predominant amount of shrinkage of the soft tissue before we go to the final zirconia. And that way, when we go to the final zirconia, you don't have them, they say 3 years down the road going, I got a whistle, I'm getting fluid underneath my zirconia, which you can fix, but it's a pain, right? So that's our typical protocol. Since we've gone to the nanoceramics, monolithic nanoceramics. So the back of the day used to be a titanium bar wrapped with PMMA. That was our long-term provisional, and those fractured a lot. We got a lot of fractures during the healing phase with that. And it makes sense when you have more components in a system, you have more possibility for failure. But once we've gone to the new nanoceramic, we just don't have fractures in those long-term provisionals. And the really cool thing is that even if we did, we can print a new one in 23 minutes. So if we had to, we just print a new one and bring them in and just unscrew it and put a new one in. So we can manage that really well. But I think that it's interesting that we should probably, and this is something in the industry that we don't really discuss too much. There's two kinds of problems that people talk about when we talk about complications. We talk about forces and stresses and these kinds of things a lot, but there's the risk to the mechanical operation. There's the risk to the biological, right? And the literature is pretty clear now, whereas we used to think that there was a significant risk to the biologics of force that was predominantly taught by Carl, right? Carl Misch. And he was worried about overstressing the bone, and that would cause bone loss. But we know that there's no evidence that that happens, okay? So you can put a lot of stress on the bone, and if you think about it, the purpose of the bone is to carry load, right? That's what nature made the bone for. It's designed to carry load. So that kind of concept goes away. So when you really talk about what are the risks when we have a cantilever to our system, the real risk you're talking about is mechanical. Okay, so we can call it biomechanical because it's part of the body, but what you're looking at is fractures of the prosthesis, or like you said, it's screw loosening, it's abutment breakage, it's abutment delamination from your prostheses. These kinds of things, those are the predominant problems, and the literature is pretty clear on that too. We're seeing 3 to 4 times more of those than we are the biological one. So what oftentimes happens is when you have a case and you have a failure, like an implant that doesn't integrate properly, it's so many reasons why it could not integrate, right? I've got 52 that I've listed. It just at the high level, you could go even deeper if you wanted to. So when you have a failure, sometimes it's very difficult to differentiate between, I think this failure was because of mechanical loading, or this failure was because of biologics, right? And what I would argue is that the vast preponderance of failure to integrate are biological in nature, okay? In other words, we didn't get the implant in the right location. We didn't get enough bone around it. There was a failure to get good wound healing, and then the implant, it partially integrates. It has stability, but it doesn't integrate long term, and so you get a failure downstream. So getting that implant in the right location in the very beginning is really paramount to preventing these kinds of problems happening later. Then the second part is if the implants are in the right location and your prosthesis is properly designed, you're going to minimize your off-axis loads, i.e. you're going to minimize your cantilevers or eliminate them in the cases of doing the remote anchorage. And that's a really good thing for the system, right? So if you do that, that's great. But if you do everything that I'm talking about in terms of the method that I described earlier, where the implants are in the right location, they're axially loaded, you've got a tall prosthesis, and it's made out of strong zirconia. We've never had a zirconia fracture. We've never had a zirconia prosthesis fracture ever in our entire career. And Tischler, Tischler took the payday. He's gone now, right? But he when he was working, he published a really neat paper. I think it was 2,500 FP3s that he did. He had like a less than 1% complication, and of those, I think he had really a good explanations for why they broke. So I think that it's pretty clear that if you have enough height to your zirconia, you're not going to have a lot of problems, right? You're not going to have a lot of fractures and such. So that's really the key. And when we see a lot of people are pushing for FP1s, right, traditional crowned height space, where your connector space between an FP1, your connector space gets very, very tiny. And if you have a very tiny connector space and your implants are spread out like an all-on-4, and your beam length is long, they're going to break. They're going to break all day long. And then you start looking for, well, why are they breaking? And if you say, well, maybe remote anchorage, so I don't have this cantilever. Well, that makes a lot of sense. But you see, it's more than just one variable, isn't it? It's a combination of variables that if we put together, it's all about reducing that risk and improving the outcomes for the patient. But you got to take a look at it more than just one parameter that you're doing in order to have that kind of success.
So you bring up an interesting point with respect to the loading of the implants. Now, it does sound like you're making a few different points here. For one, we can compensate a bit for the presence of a cantilever by having implants in the correct location, and I assume, since you mentioned axially loaded implants, that you also mean that the implants are being axially placed, which is kind of implied that is what you consider to be the correct location. So in a lot of patients, one of the main reasons that we have tilted implants is all-on-4 in the Paul Malot technique is because of the anterior board of the sinus. You're tilting an implant in order to obviously decrease that cantilever, and you're tilting that. And so I guess really the contrast here is you have, in one case, you might have 6 implants anterior to sinus placed axially. Perhaps you have a subantral short implant right, and some mitigated cantilever, we've managed to get the patient back to first molar, versus having the tilted configuration that's more typical in the palm-below, and then having the pterygoids as well. So I know we're talking about biomechanics. I know we're talking about how the implants are loaded. I guess it really is kind of a question of, is 6 implants with no pterygoids placed axially going to be better biologically or mechanically versus those tilted implants? How do you kind of, what are the different things that you're considering between those two, modalities? Because they are very different, right? You have long implants that are tilted versus shorter implants placed straight. What is kind of the rationale?
That's a great question. And this is something that a lot of doctors get really confused on, especially those young ones, Doc. When they come out and they're like, wait a minute, I thought you said you want to actually load your implants, but how do the all-in-4s work? Because you've got a tilted implant there. And they get really confused. So let me clear this up for everyone really, really simply. If you're doing a single implant, the way an implant is designed, it's designed to be loaded axially, which means all the forces should be directed down through the long axis of the implant, okay? Anything that you do that creates a bending moment on that is going to create problems. So if you get the implant in the wrong location, let's say you're doing a first molar and you put the implant in and you get a little pucker factor, so you scoot it a little bit towards the distal, and now you got a cantilever to the mesial. So you got a cantilever. If you look at the two-dimensional radiograph, the crown that you put on there looks like a Snoopy, and so I call it a Snoopy when you see it. It's got a long nose on one side, right? It's short on one side, it's long on. That's a cantilever on a first molar. Well, every time they bite and they hit the mesial marginal ridge of that prosthesis, it's going to bend that. It's going to bend that. And what you're doing is every time you're bending that prosthesis, you're torquing the entire system. So you're putting the stress onto the abutment screw. You're putting the stress onto the cement that cements the zirconia crown to the hybrid tie base, and the hybrid tie base to the implant. So none of the system, none of it likes that, okay? So you want to prevent that off-axis loading. You want to load axially. So that makes a lot of sense. Would any of you think it would be a good idea to place a single implant at 30 degrees and load it with a crown? And I think all of you would say, well, no, I don't think that's a good idea at all, right? So, and I don't know that I've seen anyone actually do that, where they've placed a single implant at a 30-degree angle and then used a 30-degree correction to design a single crown. However,
in Turkey.
In Turkey?
Yeah.
Yeah. Crazy.
Well,
we see a lot of cool stuff in Turkey.
Yeah.
Well, y'all have all seen the lateral incisor implant where it's like coming like this, and then I think they put maybe like a 55-degree or like a 60.
You're going to have to share some of those pictures with me, guys. I want to see that.
And it looks terrible. The bone regeneration doctors in New York, they get these things all the time.
Sure.
I would like to see some pictures of that. Please share. That'd be great.
That's good.
But then now here's, because you're waiting, so you want to know, well, how do angled implants work when you do an all-in-X? You change the complete dynamics. It's called, in engineering, it's called a truss. Okay. If you're going down the interstate and you see one of those signs across that's bridged across, it's got it tells you what interstate you're on. It's made out of a series of bars, and those bars kind of go zigzag like this, right? And that's called a truss. Yeah. And what happens when we put something into a truss, all of the elements that are loaded in the truss are loaded axially. Right? Are you guys getting this? So when you tie an axially implant with an off-axis implant, and you tie them together with a prosthesis, and at the base they're tied together with bone, you've just created a truss, which means that implant is not being loaded off-axis. It's being loaded axially, which is something that I always wanted to talk to Carl about that, because Carl would always say, he remember that debate he had with Paul Lavala, right? It was brutal, right? They were on stage and they were going at each other, and he was like, "Would you build a tree house for your kids with posts like this?" And he was like, "No, you wouldn't," right? But what he wasn't talking about, and what he was failing to kind of bring to light, was that it's not a single implant; it's a system. Right. And a system together is a truss. And if you put the truss together, it's incredibly strong. Which is why when you put your prostheses on top, it should be rigid. So there was a time where people were thinking, maybe I should put some like a small, an elastomer type of plastic on the top that would give, right? so that it would absorb the occlusal loads and such. That's a terrible idea, because now your implants are going to be not rigidly coupled, which means they're going to be allowed to bend. And that would
you lose that truss factor.
You would lose that truss function, and it would fail. So that's why using something really rigid like a nanoceramic, or even more rigid like a ceramic, like an oxide like zirconia, that's why it works. So that is a distinction that really, I hope that if people are listening, they really understand. There is a huge distinction between loading individual implants and tying them together in a prosthesis. It's a completely different animal.
Right. I mean, that's why we see our implant success in all on X be so much higher than our single units. But I still would prefer a longer implant in the pterygoid than a shorter implant subantrally. And it's not just length or location, it's really kind of more type of bone. That the bone in the posterior maxilla is oftentimes just garbage, and it's not something that I want to really sink my teeth into, right? And going back to the truss, when you look at those pterygoids, then if you look at many of my cases, it's leaning back into the pterygoid, posterior superiorly, and then you've got the posterior ones leaning anteriorly in front of the sinus, and then when I do the nasal crest, everything is at an angle, and so it's a huge trussed web. So I'd like to encourage you, Dr. Stanley, to consider doing some pterygoids.
I would love to. I love to do everything in this planet, and I'm running out of time. My days are becoming limited. I just told a colleague this morning, I said, I've got to start telling people no. And he said, what do you mean? He says, I'm burning the candle at both ends here. I'm trying to get my book written, and on top of all the other things I'm doing, I'm like, I gotta start telling people no. He started laughing because he knows I'm never going to do that. So yeah, I'd love to do it, because why not? I mean, learning, the only way to improve yourself on this planet is to learn, right? And so learning is paramount, right? You got to keep expanding. You got to keep learning.
Yeah. And
So-
one of the reasons to actually do a pterygoid is because the best zygoma is the one you never have done.
Yeah.
Expand on that.
I think we can all agree to that.
So we can use. I started doing zygomatics first in 2014, 2015, and then I started branching out in 2016, 17 into doing pterygoids. And interestingly enough, we didn't have osteotomes, so I drill my pterygoids, and because we didn't have the instrumentation, and so that's how I learned and developed my technique. But I would have saved myself the hassle of doing lots of other zygos had I been able just to pop in a pterygoid. Literally, I've got a video start to finish with the abutment on, I think is like 2 minutes and 19 seconds from initial osteotomy. And so, they go really well, they go really fast. You've got to get your angles right, or you can be in the three neighborhoods that you don't want to be in, right? Lateral, 2 anterior, and 2 superior, you hit the big red IMAX. But I do tend to think, or I know that the risks of pterygoids are, I think, overstated, and I think it's wise to have an appreciation for the risks and the danger, but I don't really feel that a properly trained individual is can really risk the life of a patient. Now, that being said, I have seen a properly trained individual with a 25 millimeter implant, way in the back, very close to where I think the IMAX would be, And I don't know what that individual was thinking when they did that, but even in a trained individual, there are, you can get disoriented. Maybe, I don't know. I wasn't there, but the X-ray looks pretty bad. But I think that pterygoids help us avoid zygos.